Hello, thank you for coming. Thank you, Christophe, for inviting us to speak this morning. When I come to these conferences on addiction, people talk to me about lots of interesting subjects. I'm a therapist, so what I'm interested in is treating addiction. How do we get people out of their problems? New products, legalization, policy, addiction policy, that's very interesting. But what I'm interested in, and I don't see people speak about it too much in conferences. What interests me is helping people get out of their problems. So this is the subject I've chosen, and with my colleague Lisa, my kind colleague, we're going to talk about treatment, how to help people. As far as I'm concerned, I've been working for a long time in centres and clinics, treatment clinics and centres in France and abroad, where I've had the opportunity to encounter different models and techniques, different methods, and also meet hundreds of addicts and identify their needs, how they work, their characteristics, the key points when they stop using drugs. So based on my observations, I've built up a list of factors which allows us to build a program for treatment. So that's the plan. I observe. My starting point is clinical observation, and I find a therapeutic application for that. The first thing we see in these centres, it's a bit like in schools and high schools. There are good students. The context is addicts. There are who have come to the centres to get out of their addiction. That's the residential context. We are with addicts. These are not big drinkers or little drinkers. They're real addicts who want to start, or who want to stop rather. Most of them. The first thing in this centre is a bit like a school. You have the good students and the bad students. The good students go to all the working groups, they're super interested by everything, and the poor students, they criticize everything and they don't want to do anything. That's an issue for therapists, for group therapists. So what happens is that they're not in the same stage, they're not at the same stage in their road to recovery. There are two psychology professors, American professors, who established a model with 6 stage. I simplified it here. They're called the Clementine Prochaska, and I've made just 4 stage towards recovery. Denial is the first one. In the center, there are people who are in the center at every level, every stage of recovery. Some people have been sent there because their boss has said they need to get treatment, otherwise they're fired. Some are being threatened by their wife to get divorced. Some people have come on of their own free will, but that's not the majority. So there are people at every stage of recovery. So denial, everyone knows. They only feel the benefits of using the drug. They don't want to stop. There's no problem as far as they're concerned, but they're still there in the center. The next stage is those who contemplate or envisage possibility of stopping use. They might have symptoms or consequences of their drug use. Third stage is action. They're asking for help. They're looking for information. They're active in their approach to stop. And final stage, maintenance, strategies to stay clean, how to remain clean. Therapeutic application of these observations next is to do a preliminary interview at the start, a sort of pre-admission where you can determine what stage your patient is at. That way, when they're in the group, in the center, and you won't focus, you won't be trying to convince too hard a patient in stage 1. The idea is to establish a satisfactory therapeutic relationship, to converse with him or her, and maybe in the course of this conversation you'll help him or her realize there's a relationship between their problems and their drug use, so they move from stage 1 to stage 2. If you focus too much, if you increase their resistance and they leave the center. So before admission, it's very important to see where they are on the spectrum. And we're going to move on to the second point, is the problem of addiction for the addict. What's the problem? Because there are lots of advantages. They're high all the time. That's a nice situation. What's the disadvantage for them? The main issue is stopping. In fact, when you're addicted, the idea of stopping, being able to consume, is a source of anxiety. They've always had a time where they felt this withdrawal. For alcoholics, it may be the shop is closed. For addicts, it might be the dealer is on holiday. They've all experienced this feeling of withdrawal, and they don't want to experience that. So going to a recovery center, and stopping, that's unthinkable. So what's the problem for them? There are those who come back to the center, they all have a sort of abnormal reaction. When they take the first dose or the first glass, the obsession to finish the bottle takes hold. That means they've lost control again of their consumption. After the first dose or the first glass, they talk about it kind of like an allergy. The third problem for addicts with regard to stopping is the disconnection with their lifestyle. Addicts get up, they need to get money, then they need to call the dealer, then they wait, then they're busy all day. And he has his packet in his pocket, he needs to look out for the police. It's a lifestyle. It's not our lifestyle maybe, but for these people who often come from a kind of existential life, filling up their day with that's a big part of their life. Stopping that and coming back to what they imagine their future to be, that's also unthinkable. So the therapeutic applications of these three observations. For the first one, we need to explain that weaning has now become comfortable, in inverted commas. At clinic, no one's suffering from withdrawal. Second observation, with respect to the obsession of the loss of control after the first hit, is that you need to add value to the idea of abstinence. The third therapeutic application on the disconnect with a certain lifestyle, the solution to that is to bring former drug users into the clinic to show them that this transition to a new lifestyle is pleasant. Plenty of them find work. Many of them are attractive for people, good examples for people who are hesitating about changing their lifestyle. Third important point is the delay in the psychological development, the immaturity, you could say, of the addicts. The average age is 40, 50 years. So you have people who, sometimes executives, businessmen, and suddenly their activity, afternoon activity, is removed, and they have a tantrum like a toddler. 5 minutes later, we give them something else, and they're all happy. There's another type of person who will put the radio on all night with the window open, and he'll be surprised that people are unhappy about it. There is an immaturity, a lack of maturity. So we explain this immaturity with theories on attachments, by the fact that isolation, sensory and emotional isolation, has neurological consequences on cognitive development. So there is a delayed psychological development of these people. Most addicts, when they talk about their history, their story, many of them have suffered from deficiencies or lack of affection. There was no other effective other, or emotional, affectionate other, I should say. There are addicts who use drugs every day. This layer, they get up and they go to bed high. They don't have this ability to incorporate their lived experience because they're high. Every night they wipe the slate clean. In fact, that's why we see addicts often make the same mistakes, because they don't capitalize on their lived experience. So therapeutic application of these on these 3 points. So this is attachment theory, basically. So we need to present a comforting and reassuring program that will reignite or restart the brain, which will restart the psychological development. Point B, due to this immaturity in the first weeks, you need to take this immaturity into account, and you can't count and don't hesitate to drive them. Even if they're 50 years old, they seem mature, you need to tell them to go to the discussion groups. You need to drive them, because they don't have this sense of responsibility. They're not used. You can't rely on them to look after themselves. And the final point, it's the same. You need to ensure that the context, the environment, is safe, that they can internalize. Most addicts are what psychologists call borderline cases. They have problems with limits, and often they didn't have a maternal figure who set limits in their teenage years. So it's important to offer a framework that they'll be able to internalize, a safe framework. For them, a framework, a context will help them accept the environment if it's safe. Fourth point, so that was a bit of psychoanalysis. This is an extreme case that shows the effect of isolation, emotional isolation, in children. They did brain scans of the Romanian orphans, and you see I said there was a neurological impact, and this is the extreme case. You can see the brain on the right is the frontal cortex and limbic system is smaller, and this recovers when they are put into safe places and institutions. A year later, you do more scans, and the brain has recovered a normal function. Hence the idea of having in our centres a safe context, a safe environment, a safe a base. We'll talk about it in the next points. The fourth point is the identity problem, the identity issue. Being high, using psychotropic substances has caused a gap in the continuity of their existence. They don't capitalize. There's no reflection on their lives. There is a gap which creates an identity gap. The therapeutic application is to create situations where they'll be able to work on their narrative, their lifeline, to remember what happened to them. They can spend a long time, a week, 10 days, to trying to remember, and as a group they will tell their narrative. That recreates or helps them to recreate an identity. So this is the start of the curative process, the healing process. So here you have the timeline and the narrative. It's the inability to be alone. We also see in the centres when they arrive, when we take an activity away from them, they panic. They're alone with themselves, alone with their thoughts. The fact that they've not had to be alone while they were using drugs means that they were absent that whole time. So at the start of the recovery process, they find themselves alone with someone they don't actually know. Hence this sense of loss, that something's missing. This creates anxiety. So the therapeutic application here is to create a program with a lot of structure, a lot of activities, at least in the start, because we have 3 programs. We have a therapeutic community program where people can stay a long time, and when you go from one program to another, suddenly they stop. They don't have this daily busy agenda, and they find themselves with a softer or a less busy daily program. So there you have the cravings, the withdrawal symptoms that come back, because there are gaps, there is downtime, there's times where they're not working, and that's where the cravings come back. The use of a therapeutic model. So this is very important. When people arrive in our centres, they tell us about their history of care, in the past. So it's often ongoing. It's been going on for 10 years. They've seen loads of psychologists, psychiatrists, doctors. They've been to different centres, and they're not always satisfied. So they're fairly skeptical about the ability of therapists to help them. So to reassure them, we use a model or method that is recognized. It's been around for decades, and which has been scientifically proven as the method, the most successful model currently around. This is what we call the integrative model now, the rehabilitation model, and it's the inheritor of the Minnesota model. The American government financed major studies over 10-15 years to prove not the superiority, but to prove the fact that the people they use this model stay clean for longer. The question of medication, also highly important. We can see during the day when we have people who are feel like they're anxious, they become anxious. The group starts, and you see them clapping their hands. You can see them focusing on themselves. They start to focus their attention on one of the stories of one of the members, and gradually their face, they start to smile, and half an hour later they're laughing, and they go out. So it seems like they've taken a hit. So you mustn't underestimate the calming effect of being in a group. There's another important point, is that after the weaning period, they all go through a depressive phase, when they start to become lucid, to become aware that their life is chaotic, that they lost their job, they lost a lot. And this awareness, and obviously this depresses them. However, this phase is crucial. It's really the fertilizer that will help them to change, to prevent them starting again. So you mustn't gloss over this depressive phase with antidepressants. It's very important. This depressive phase is the door to recovery. You need to let them feel the consequences of their drug use. On the other hand, you have to obviously have a program that supports them. You mustn't leave them. So our program supports them with groups, with so therapeutic application here is avoiding high doses of medications. Of course, we don't touch psychoactive treatments. There are all the medications that, as we said, point 1 and 2, all these weaning products, we don't use them, or psychiatric treatments. But here I'm talking about medication during the therapy. Obviously, addicts every evening, they go to the pharmacy to ask for medication. So you need to put them in groups, and it passes. So an evolving program. And when they arrive, some of them feel they're burnt out. Their brain is burnt out. The toxicity of psychoactive substances, when they arrive, they feel burnt out. So you need a program that takes into account the cognitive and behavioral recovery of the patient. And here I've written how we structure this evolution. The first week is weaning and stabilization of the patient. Then it's more recovery, narcissistic recovery. We need to go gradually. It's more about helping them learn to love themselves again. Restoring attachment. Going back to the theory of attachment, which is very important, we realize that patients become attached or start to talk not necessarily to the therapist or the one with the most diplomas. They will become attached to the gym teacher or the chef. So it's very important to have a team, a pluralistic team with no hierarchy, where patients can go to talk to everyone. We don't see a difference between the boss and the chef. They're all accessible. That's very important. Do you want to move on to peer helpers?
In a lot of countries, you notice that amongst doctors, psychologists, psychotherapists, amongst doctors and psychologists and so on and so forth, you also have people who are also addicts or who are also recovering addicts and have been recovering addicts for a long time. So what I have observed ever since working with Philippe, I am not personally an addict, but I know that patients, when they come in, they tend to turn to psychologists, doctors, psychotherapists who are addicts. They feel that they are better understood by those healthcare professionals who are addicts themselves. They tell me, they tell others, non-addict people, that we cannot understand them. It's just after a while you manage to create a proper treatment relationship with them. But peer helpers, professionals who are also addicts, make it possible for patients, for those people to feel safe, to create a secure relationship. And as we have seen in the past, from an emotional perspective, that makes it possible for them to open up to the outside world. Once that link has been created, the patient can open up and start developing again, start working on cognitive and emotional development. From then on, you can start working on other things. So those professionals are more credible. It's easier for patients to trust them, especially over the course of the first days or the first weeks, and that's very important in order to it's very important to integrate recovering addicts to your teams. That seems essential. So the 11th point that we wanted to raise had to do with a group approach, learning or relearning otherness. One of the characteristics of addiction is isolation. Especially over the course of the past few years, we know that alcoholic addicts, or rather alcoholic addicts tend to isolate themselves. They lose their social abilities. They lose social codes, and it's extremely important to get them to work as a group, because within a group they will be able to see the impact that their behavior may have, their isolated behavior may have on others. So that will make it possible for them to automatically readjust. And instead of us telling them, don't do this, don't do that, there's a kind of a mirror effect within a group where they can see their mirror image in other addicts, and that is much more interesting and much more efficient in terms of recovery. So again, for treatment, I think the group approach is really key. Okay, so then we also wanted to mention the idea of time to recovery, or the duration of recovery. This is not something that is going to be solved within 4 weeks. When you stop taking whatever substance you were addicted to, your problems neurotic issues or the original issues that you kind of self-medicated with substance abuse will tend to reappear. Problems that have never been treated in the past or that have been treated via toxic self-medication, and that reappears, and 4 weeks are not enough. The treatment approach, I mean, during the 4 weeks of treatment, and especially during the last days, it's very important to establish with the patient a post-cure plan, a support plan that will take into account that reappearance of neurotic behaviors or issues. And in those cases, we tend to offer post-cure group support or peer support or the 12 steps programs, or maybe the possibility to see a therapist. But if the original neurosis is not treated, then the tension will be such that they might relapse. And I think this is very important for us to remember, and it's very important to insist on it during the cure. You can't just let them go after 4 weeks and hope that everything will go well. This is just the first step. This is but the beginning. Now, making sure to involve close family and friends. After years of being an addict, the relationship with your environment, very often the relationships have been damaged. And what's particularly interesting is that sometimes the addicts are not aware of it. They weren't really there in a way, so they're not aware of what they put their close ones through. Or they put their families through, their partners, their children, their parents. They might have spent 10 years not sleeping. They have no idea. The addicts, they don't know that their parents haven't slept a wink in 10 years. So it's very important to involve the patient's family and environment in the treatment program. So we can invite them on the weekend, and during those days you have interviews that can be organized, treatment interviews, where carers and close ones can come and talk about what they have gone through. The idea being that it's going to make it possible to appease the relationships with the families, with the friends, and that will make it possible to re-establish the possibility for exchange, for relationship with the family, relationships that are going to be very necessary to the addict once they leave the residential center. The positive impact of spirituality. Now, we have noticed that patients who manage to there's that idea of religion-free spirituality, the idea of meditation, the notion of a higher power. Those who manage to find a way to use this generally find it a very useful tool. The benefits of meditation, for example, I think there is something about wellness, or what is it, mindfulness, I think, that's working quite well. And so it's quite interesting when they are at the center to take them also to the 12-step program meetings, because they will be able, throughout the cure, they will be able to kind of try to understand what's happening during those meetings of the 12-step programs. They can come back and they can say, what's the deal with the higher power? I don't understand it. So they have 3 to 4 weeks to kind of integrate those notions. And when they leave the center 4 weeks later, it has become a type of reflex. It's no longer mystifying to them. It's no longer a foreign notion. And yes, I So those were the 14 main points. You have a lot of other points that we could have raised, of course, but that's, I guess, the basics that we wanted to talk about, and I guess that's more or less it. In terms of medication treatment, I think very often it's important to simplify things and to try to listen, always listen to addicts and to their needs. And from that starting point, I think you can, on that basis, rather, you can create an efficient model for treatment. Thank you very much. I think I'm done. One question, maybe just one. There's no microphone, so there's no translation. Sorry about that. There we go. When you talk about the depression phase that patients go through, do you explain to them that this is going to be helpful for them in the long run? Of course we do, of course. In groups, we have something that we call the psychoeducational groups, and we spend our time describing the disease, trying to find a deeper meaning behind what's happening to them, so they do know what's happening.